Hello and welcome. Today we'll be discussing a potentially serious complication associated with the use of cyclosporine nephrotoxicity. This condition affects the kidneys and can have a significant impact on overall health. So let's dive in and explore what it is, how it develops, and what can be done about it. So, what causes cyclosporine nephrotoxicity? Cyclosporine is an immunosuppressant drug commonly used to prevent organ rejection after transplant surgery and to treat autoimmune diseases like rheumatoid arthritis and psoriasis. While effective at suppressing the immune system, cyclosporine can also damage the kidneys. The higher the dose and the longer the duration of cyclosporine use, the greater the risk of developing nephrotoxicity. Other risk factors include pre-existing kidney disease, the concurrent use of other nephrotoxic medications, and certain genetic predispositions. To understand cyclosporine nephrotoxicity, it's important to know how cyclosporine affects the kidneys. At a cellular level, cyclosporine primarily impacts the arterioles that supply blood to the glomeruli, the kidney's filtering units. It does this by causing vasoconstriction, or narrowing, of these blood vessels. This constriction reduces blood flow to the kidneys, leading to decreased glomerular filtration rate, or GFR. In addition, cyclosporine can directly damage the kidney tubules, the structures responsible for reabsorbing essential substances and excreting waste products. This damage can manifest as tubular atrophy and interstitial fibrosis, meaning a wasting away of the tubules and scarring of the surrounding tissue. These changes ultimately impair the kidney's ability to function properly and filter waste from the blood. Determining the exact number of people affected by cyclosporine nephrotoxicity is challenging. This is because the prevalence varies based on the underlying condition being treated with cyclosporine, the dosage used, and the duration of treatment. Studies suggest that a significant percentage of transplant recipients treated with cyclosporine experience some degree of nephrotoxicity, ranging from mild dysfunction to chronic kidney disease. The incidence is also noteworthy in patients receiving cyclosporine for autoimmune disorders. It's important to highlight that careful monitoring and dose adjustments can help minimize the risk. The signs and symptoms of cyclosporine nephrotoxicity can be subtle, especially in the early stages. Patients may not experience any noticeable symptoms initially. As kidney function declines, however, symptoms may include elevated blood pressure, fatigue, fluid retention leading to swelling in the legs and ankles, decreased urine output, and changes in electrolyte levels. In more advanced cases, patients may experience nausea, vomiting, loss of appetite, and confusion. Regular monitoring of kidney function is crucial to detect nephrotoxicity early before significant damage occurs. Diagnosing cyclosporine nephrotoxicity typically involves a combination of methods. Firstly, monitoring of serum creatinine levels is essential. An increase in creatinine, a waste product filtered by the kidneys, indicates reduced kidney function. Secondly, measuring the estimated glomerular filtration rate, or eGFR, provides a more accurate assessment of kidney function. Thirdly, a kidney biopsy, where a small sample of kidney tissue is examined under a microscope, can help confirm the diagnosis and assess the extent of damage. Finally, ruling out other potential causes of kidney dysfunction, such as infection or obstruction, is necessary to ensure an accurate diagnosis of cyclosporine nephrotoxicity. While cyclosporine nephrotoxicity doesn't have distinct types, it can be categorized based on its severity and chronicity. Acute nephrotoxicity occurs relatively quickly after starting cyclosporine and is often reversible with dose adjustments. Chronic nephrotoxicity develops gradually over months or years and is characterized by progressive kidney damage that may be irreversible. The severity of nephrotoxicity is typically graded based on the degree of kidney dysfunction and the presence of structural changes seen on kidney biopsy. The primary goal of treatment is to minimize further kidney damage and preserve kidney function. Dose reduction or discontinuation of cyclosporine is often the first step. Switching to an alternative immunosuppressant drug that is less nephrotoxic may also be considered. Medications to control blood pressure, such as ACE inhibitors or ARBs, can help protect the kidneys. In severe cases, dialysis may be necessary to filter waste products from the blood when the kidneys are no longer able to function adequately. Careful management of fluid and electrolyte balance is also crucial. Preventing cyclosporine nephrotoxicity is paramount. This involves using the lowest effective dose of cyclosporine, closely monitoring kidney function, including serum creatinine and eGFR, and avoiding other nephrotoxic medications whenever possible. Maintaining adequate hydration and controlling blood pressure are also important preventative measures. Patients should be educated about the potential risks of cyclosporine and instructed to report any concerning symptoms to their healthcare provider promptly. The prognosis for cyclosporine nephrotoxicity varies depending on the severity and duration of kidney damage. Early detection and intervention can often prevent or slow the progression of kidney disease. However, chronic nephrotoxicity may lead to irreversible kidney damage and, in severe cases, end-stage renal disease requiring dialysis or kidney transplantation. Ongoing research is focused on developing strategies to mitigate cyclosporine's nephrotoxic effects, such as exploring novel immunosuppressants with fewer side effects and investigating protective agents that can prevent kidney damage. Researchers are also exploring ways to personalize immunosuppressant therapy based on individual genetic profiles to minimize the risk of nephrotoxicity.